Hi, my name is Natasha Petry, and I am an associate professor of practice in the pharmacy practice department at North Dakota State University. And I am here presenting on our project, the impact of pharmacogenomic testing on medication outcomes in long-term care. And I am presenting on behalf of my team, which includes Tamara Ruggles, who's also a pharmacist and a board-certified geriatric pharmacist, Mark Dewey, pharmacist and board-certified geriatric pharmacist, as well as two more pharmacists, Elizabeth Skoy and Lisa Nagel. Here are some key abbreviations in my presentation today. And this our project is really just to take a look at what pharmacogenetic testing could do as far as medication outcomes to deliver healthcare in a specific long-term care population in the Bismarck-Mandan area. And we really want to take a look at drug-gene interactions, the prevention of adverse drug interactions, hopefully optimizing medication regimens, and then improving patient quality of life through looking at pain as well as depressive symptoms. So we are looking at a prospective cohort design to evaluate the effect of PGX testing on actionable gene-drug interactions in long-term care patients. And we will do this by getting a pharmacogenetic test on any patient who has consented to have this done. And it's generally just a simple cheek swab, so nothing too invasive. And then when we get the results back, and this will mainly be Dr. Ruggles, who is the long-term care pharmacist in this setting, doing medication reviews and seeing if any modifications need to be made. And that might be a dose adjustment or changing medications based on the gene-drug interactions identified. And so we will look at the gene-drug interactions at the time of the PGX results being returned, and then also take a look 30 and 60 days later following that PGX intervention to see if we've been able to decrease that number of interacting or potentially interacting medications. And we are going to take data from their record, their patient medical record, and then use descriptive and inferential statistics to assess that impact of gene-drug interactions. And we are looking at patients who are greater than 65 years old, have multiple comorbidities, and who would qualify under the term of polypharmacy, so 5 or more medications. And so something else that we want to look at is the number of medications prescribed, as well as taking a look at if we can have pain and depressive symptoms improve by helping to optimize their medications using pharmacogenomics. So we're going to do a medication count before and after PGX testing. Can PGX testing help reduce polypharmacy? And then we are also going to take a look at pain scores and depression scores using PHQ-9 and track those at baseline as well as 30 and 60 days following PGX testing. And using a Mann-Whitney-U test to compare pre and post intervention medication counts, as well as some descriptive statistics and more you can read on the slide there, including paired t-tests and some non-parametric tests, for example, the pain score data. We are expecting to see decreased significant gene-drug interactions following pharmacogenetic test results, as well as more optimized medication regimens, which would then hopefully lead to decreased pain, as well as better controlled depressive symptoms. And so, in conclusion, adverse drug reactions are a leading cause of death in the United States, and pharmacogenomics is a useful tool to kind of detect some of those potential adverse drug interactions through gene-drug interactions. And so our goal would be to decrease those adverse reactions and optimize medication use, specifically taking a look at polypharmacy, the number of medications, pain scores, as well as depressive symptoms. And so there is research out there as far as benefits of pharmacogenomics. The studies are very limited in long-term care population. And so we're really interested to see in a group that's usually on more medications, usually experiencing polypharmacy, a population that usually has, a good number of comorbidities, to take a look and see the hopeful value that pharmacogenomics can provide in optimizing care for these patients. So really, by optimizing the care, we're looking to decrease adverse reactions and then improve measurable outcomes. And then if we can decrease the medication burden for patients as well, that would be wonderful. And so I want to say that I am so sorry I cannot be there in person today. Did not work out with my schedule, but I am disappointed not to be there with you all and hearing the great topics for the day and networking with you all. But appreciate the opportunity to record a presentation for you all to watch and learn about our project. And so special thanks to the TRANSCEND team. They've been absolutely wonderful to work with, as well as acknowledging Dr. Rebecca Brynjolfsson, a geriatric pharmacist at NDSU on faculty, who really helped connect some of us together to put a proposal together, as well as gave us, input on some of our initial ideas. And with that, I will end and thank you so much for your time.